In this PowerPoint, we'll be reviewing diabetes type 1 and diabetes type 2. Diabetes is a chronic multisystem disease where there is a disorder of glucose metabolism. We usually see that hyperglycemia, and there's a variety of reasons we can see that. It can be from abnormal insulin production, either absent insulin supply, insufficient insulin supply, or impaired insulin utilization, or all of the above. The problem is that long-term complications make it a devastating disease. The American Diabetes Association recognizes 4 classes of diabetes. The 2 most common ones that we're going to talk about are type 1 and type 2. Gestational you should have learned about in OB, and then there are some other ones that we're really not even going to talk about. So this image shows how normal glucose and insulin metabolism occurs. So in the first hour or two after meals, so here would be the meal, notice here the insulin concentration is going to rise and peak at about that 1 hour. And then after the meals, the insulin concentration declines toward preprandial values. And preprandial means before meals, just a fancy way of saying preprandial, before they eat. As the carbohydrates are absorbed from the GI tract, declines after the carbohydrates is complete, and during night, notice that the insulin concentrations are low and fairly consistent. There is a slight increase at dawn, meaning when they wake up. So with normal glucose metabolism, insulin binds to the receptors along the cell walls of muscle, adipose, fat tissue, and liver cells. The glucose is transported by proteins and then attached to the cell wall, which allows the glucose to enter the cell where it is either stored or used to make energy. So without insulin to unlock those cells, it's not going to get in there. So normal glucose is 74 to 106. And as we know, as we've been talking about labs all semester, the labs of what's normal at one hospital might be slightly different than somewhere else. But generally speaking, 74 to 106 is considered normal. Anything over 200 with classic symptoms of hyperglycemia, meaning that polydipsia, polyuria, and polyphagia, can be diagnostic for diabetes. Now, a fasting blood glucose, meaning that the person has not had any caloric intake for 8 hours, again, that 74 to 106 is normal, and then greater than 126, greater than or equal to 126, would be diagnostic for diabetes for somebody who has had a fasting blood glucose. So other testing could be an oral glucose tolerance test, and you learned about this in OB. This is where we give the patient a glucose load of 75 grams, and then their blood sugar, if it's greater than 200 at 2 hours, then that would be diagnostic for diabetes. And then the other way is the glycosylated hemoglobin A1C, or hemoglobin A1C. Normal is 4 to 5.6. Prediabetes is 5.7 to 6.4. And good diabetic control is less than 7, although the American College of Endocrine really wants it less than 6.5. Again, that A1C greater than 6.5 is diagnostic for diabetes. So with type 1 diabetes, this is considered more of an autoimmune disorder. Some sort of flu or whatever has happened, the body develops these antibodies against insulin or the beta cells that produce insulin, and these antibodies are present for months or years before the symptoms actually develop. The symptoms do develop when the pancreas can no longer produce sufficient amount of insulin to maintain the normal glucose, and that's why those symptoms are often rapid, and we'll see the patient either with impending or actual ketoacidosis secondary to this. Again, our type 1 diabetics would usually have a history of recent and sudden unintentional weight loss. with the classic symptoms of the polydipsia, polyuria, and polyphagia. They do require exogenous insulin, meaning outside of their own body, in order for them to live. Without insulin, they will develop DKA, and we know that that's metabolic acidosis and very life-threatening. And so this person will require insulin exogenously for the rest of their life, unless they get, an islet cell transfer or something like that, which we're not talking about in this class. So now, type 2 diabetes is the most prevalent type. Risk factors are overweight or obese, older adults, a family history of type 2 diabetes. Sadly, we are seeing an increase in children getting type 2 diabetes, secondary to childhood obesity, the amount of screen time, the lack of going outside and playing. Type 2 diabetes is usually characterized by a combination of inadequate insulin secretion and that insulin resistance. So the pancreas is still creating some insulin, endogenous, self-made, but the major distinction between type 1 and type 2 is whether somebody has their own endogenous insulin. So type 1 patients do not have endogenous insulin, and type 2 people still do. Now, some of the abnormalities that we'll find in type 2 diabetes is, again, that insulin resistance, where the body just doesn't respond to insulin the way that we would like it to. A marked decrease in the ability of the pancreas to produce insulin, inappropriate glucose production by the liver, altered production of hormones and cytokines by the adipose tissue, which causes this inflammatory response that happens, which then affects the ability of insulin to work. And patients who have metabolic syndrome are at a much higher risk of developing type 2 diabetes. And metabolic syndrome is having 3 of the 5 components. So either elevated glucose levels, abdominal obesity, elevated blood pressures, high levels of triglycerides, or decreased levels of the high-density lipoproteins, which are good lipids. Type 2 diabetes does have a gradual onset. The person may have it for years and not even know that they have it. It is usually diagnosed on just routine screenings, and they might even be like coming in for surgery for something else, and that routine screening, they find it with that. And so at the time of diagnosis, the patient may have had type 2 diabetes for anywhere from 6 to 6.5 years, which is scary when you think about those micro and microvascular changes that happen in the body. So prediabetes. Why do we care? We care because patients who have prediabetes are at risk for developing type 2 diabetes. Generally speaking, notice that this fasting glucose is somewhere between that 100 and 125. The number that I've usually been told is more like 110, but your textbook does say that 100 to 125. Or if they've had an oral glucose tolerance test and they're at 2 hours, their blood sugar is between that 140 and 199. Again, these patients don't have symptoms usually. But the big thing is about education. We want them to get routine screenings of their A1C. We want them to monitor for signs of diabetes, that fatigue, frequent infections, or slow healing wounds. We want them to maintain a healthy weight or lose weight if they need to get regular exercise, and to make healthy food choices to help limit the risk of getting that diabetes, type 2. Gestational diabetes, again, you've had this in OB. Big thing is they're going to have bigger babies because of all that sugar, and so higher risk of C-section. And people who've had gestational diabetes are more likely to get type 2 diabetes. So there are some other things that can cause diabetes. Things like Cushing syndrome. We know that Cushing is cortisol, hyperthyroidism, pancreatitis. Obviously, if we have inflammation of our pancreas, our beta cells are not going to be working correctly. Cystic fibrosis, again, that mucus is clogging that pancreas, not allowing the insulin to be secreted. Hemochromatosis, parental nutrition. Those are all things that can cause high blood sugars. If we fix those underlying issues, then the diabetes may just completely resolved. And then there are medications that can increase the risk for diabetes. So obviously corticosteroids, we've talked about that a lot during the year, thiazides, phenytoin, and atypical antipsychotics. So again, this is just those differences between type 1 and type 2. Type 1, rapid onset. Usual signs and symptoms are acute. Those classic symptoms are the polyuria, polydipsia, polyphagia. Weight loss, again, because the glucose can't get into the cells, and that's an unintentional weight loss. Weakness, fatigue, and ketoacidosis. Whereas with type 2, it is more gradual. The symptoms are less specific. You can see the classic signs, but it just depends. Fatigue, recurrent infections, such as recurrent vaginal yeast infections or candidiasis infections, prolonged wound healing, and visual changes. Again, we've already talked about this. What are the 4 ways we can diagnose diabetes? At A1C greater than 6.5, the fasting glucose greater than or equal to 126, and that means that they have not had any calories in 8 hours. The 2-hour plasma glucose level and an oral glucose tolerance test of 200. And in a patient with classic symptoms of hyperglycemia with a random glucose greater than or equal to 200. And those are numbers that you should know. So they usually recommend confirmation, and they want to do whatever the first test was. So if it was found on an A1C, they want to repeat the A1C. If they did it with the fasting, they want to do the fasting. A1C is the most comprehensive. It gives us that average glucose over 2 to 3 months, and that's because it's the amount of hemoglobin that's sticking, or amount of amount of glucose that is sticking to that hemoglobin, and our hemoglobin lives about 120 days. That's why it gives us that number of 2 to 3 months. It does not require fasting. However, if you do have anemia, then that can affect the A1C readings. And again, our goal for treatment for A1C and diabetes is to have that A1C less than 7 per the American Diabetes Association. So what are we trying to do with somebody with diabetes? We're trying to reduce their symptoms, promote well-being, prevent those complications related to hypoglycemia and hyperglycemia, try to delay or prevent the onset and progression of long-term complication. And this is usually going to be met when the patient is able to maintain glucose levels as near to normal as possible. So diabetes is a chronic disease that requires daily decisions about what somebody is taking in dietary-wise, their medications, and exercise to maintain that good glucose control.